Hello and welcome to our monthly review of the lupus literature. We record this podcast for you every month, so you will always be able to keep up to date on the latest literature and expert opinions. I'm Professor C.C. Mok, the Chief of the Division of Rheumatology at Human Hospital, Hong Kong. So welcome Shirley Chen, who is a clinical assistant professor in rheumatology at the University of Hong Kong. Hi, Shirley.
Hi, Professor Mok and everyone. It's a pleasure to be here.
Today we are going to review two key publications from April covered on the Lupus Forum. So the first paper we want to discuss is by Fan et al. from Guangdong, very close to us. And the title is Evaluation of the Efficacy and Safety of belimumab and telitacicept in patients with SLE, and the results of a retrospective observational study. So this is a retrospective study. They recruited around 101 patients from their hospital who were started on belimumab or telitacicept for active lupus. And because they want and to avoid bias because of the retrospective nature, they use a propensity score matching to make sure that the two groups are well balanced in the clinical characteristics. And they excluded patients who did not have 24 weeks data. So after they identified these 100 patients, they divided them into two groups, and they compare and measure the outcome, the primary outcome at week 24 of treatment. And the primary outcome is the LLS, no disease activity state. The secondary outcome was SRI-4, DORIS remission rate, and the change in lupus serology and the glucocorticoid dosages. And what they found was that there's a high proportion of patients achieve LLDAS at week 24 in the telitacicept group than the belimumab group. And the difference was statistically significant. And also, there is a significantly larger proportion of patients who could have a steroid reduced to less than 7.5 milligrams per day. However, when they compared the adverse events, numerically, there were more infections in the telitacicept group compared to the belimumab. And there are 3 cases of severe hypogammaglobulinemia, which required IVIG replacement therapy. And so the conclusion is that in this propensity match retrospective study, and telitacicept seems to have a better efficacy than belimumab in the treatment of active lupus.
Yeah, thank you, Professor Mok.
So maybe telitacicept is a fusion protein consists of the Fc portion of the IgG and the TACI, which binds to both APRIL and the BAFF. So compared with belimumab, which is just a monoclonal antibody that binds to the soluble BAFF, and this compound blocks both the BAFF and APRIL. So theoretically, it's more potent in suppressing the B cell function, the antibodies production. And there's a similar compound tested in Europe and US some years ago, and this compound was called telitacicept. And the structure is quite similar to telitacicept, which is only marketed in mainland China and not in other places, not even available in Hong Kong. But unfortunately, the telitacicept study was prematurely terminated, the phase 2, because of the infective complication. And later there was another RCT which ended up with a lack of efficacy. And to my knowledge, the last one was published in 2018, and some efficacy shown by repeating the compound versus placebo in a randomized control trial. But the drug company decided not to go further. But however, there was a phase 2 study just published in ARD regarding telitacicept in non-renal lupus, and it shows that all the dosages compared with placebo show a significantly high SRI-4 response rate. And this is why this compound was licensed in mainland China treatment of lupus. And it's not available in other places like in Hong Kong or Europe or US. It's just available inside mainland China.
So how do you think the prospect of this dual inhibition of BAFF and APRIL in terms of the treatment of SLE and maybe potentially other B-cell mediated autoimmune disease? Perhaps maybe we should have more caution in terms of the infection risk as well.
Yes, yes. I think in order to show, and it is a retrospective study, although they match the clinical characteristics at the very beginning, there's still some limitation because, belimumab was an older drug, and according to the experience of many physicians and rheumatologists, we use it at a later stage when the patient was refractory to a standard of care. Therefore, even they matched, use a propensity score matching to balance the characteristics, still those treated with belimumab were more likely to have refractory diseases. And for the newer drug, the telitacicept, and because it was produced by a drug company in mainland China, it's much cheaper than belimumab, and it's a newer drug. And I think they use it in patients with more earlier disease, and therefore it appears to be more effective than belimumab. But I think the direct comparison is not very fair because and we don't know whether the patients have a first-time active lupus flare or have a refractory disease. So to compare the two drugs, the best way is to have a randomized head-to-head randomized control trial. But I think because both drugs have been marketed, I think this is not very possible. But that's some caution about using telitacicept or etacicept because it's a more potent compound. As shown in this retrospective study, it shows a high risk of infection, hypogammaglobulinemia. As you know, in Asia, in our locality, we are worried about reactivation of viral infection like the hepatitis B. So because we don't have any experience of using telitacicept in Hong Kong, if this is available, I think we need to screen for the anticore antibodies for occult hepatitis B, and we may need to give prophylaxis like the anti-CD20 rituximab. Because it is more potent, it may cause more side effect than belimumab. For belimumab, we did not routinely check occult hepatitis B. And for other infections like pneumocystis and also tuberculosis, I'm not too worried about these two infections because and normally we will not screen for latent TB or we do not routinely give a PCP prophylaxis. But we need to screen for hepatitis B like the anti-CD20 because the drug is more potent and as shown in the RCT and also in this retrospective study, it seems that the infective complication will be higher, numerical higher in telitacicept group.
Yeah, I guess we should probably need to adopt a very different screening strategy if it becomes available. Yeah.
So let's move on to the second paper. So Shelley, can you summarize the second paper from Sun, Dr. Sun's book?
Yes, so thank you, Professor Mark. So the following paper we're going to share today by Sun's group, they examine the impact of belimumab treatment on the immune landscape in the peripheral blood of SLE patients. So we know that belimumab not only enhances treatment response, but also reduces disease flares and progression of organ damage. And therefore, there's really a growing emphasis on understanding the molecular mechanism underlying these perhaps disease-modifying properties of belimumab. So in this study, they collected peripheral blood immune cells from 3 different groups of participants. The first group comprised of healthy individuals without known medical condition. The second group were newly diagnosed SLE patients, and blood were taken before treatment initiation. And the last group were SLE patients on belimumab treatment. Flow cytometry as well as single-cell RNA sequencing were performed, and they identified 11 cell clusters with disease-specific T cell, B cell, NK cell, as well as monocyte subpopulations. So first, we'll look at the T cell compartments. And in this study, SLE patients were shown to have an upregulated CD3 positive T cells, CD8 positive T cells, which actually just highlight the role of T cell dysfunction in SLE pathogenesis. But also interestingly, they also found an upregulation of CD3 positive and PD1 positive and CD8 positive, PD1 positive cells in SLE. And we all know that PD1 is a co-inhibitory signal on the T cell, which also acts as a checkpoint for regulating T cell activation. And these were found to be upregulated in the SLE patients. And when secondly, we look at other cell subpopulation, and they found that CD19, CD56 NK cell, CD16 positive, CD14 positive, CD206 positive monocytes, and CD14, CD163 positive monocytes were reduced in SLE, as well as the ratio between CD4 and CD8 T cells. Lastly, because the focus was really mainly to look at the belimumab group. So lastly, they focused on the belimumab-treated SLE patients and found a reduction in the CD19 positive B cells, as well as reduction of the CD3 positive, PD1 positive T cells in the belimumab-treated SLE patients. The reduction in the circulating CD19 B cells is actually quite consistent with other studies. But I think one thing to highlight is this discovery or the observation that they also showed a reduction in the CD3 positive, PD1 positive T cell in the belimumab treated SLE patients. So, but one thing we need to keep in mind in this study is that it's a cross-section study. So we're not comparing longitudinal pre-treatment, post-treatment changes in most of the analysis. So the findings really warrant further studies to consolidate. So I guess it's an interesting study because it highlights the nature of SLE immunopathology is really intricate. You know, when we use belimumab to inhibit the BAF and really the B cell compartment, we really see a dynamic changes in other immune cell populations as well. So this might generate, you know, some clinical aspect that perhaps while we inhibit the BAF, while we try to work on the B cell compartment, we should also be open-minded that other cell population might be affected during the treatment.
Shelley, do you think that the change in this population, the B cell, T cell, NK cell population expected after belimumab treatment? Because in this study, they did a lot of laboratory work, but they did not specify the clinical characteristics of the patients. They just say before and after belimumab treatment, and they did not mention about other conventional medications like steroid, mycophenolate, etc. Therefore, we don't know whether the effect of the cell population change is due to belimumab alone or due to other drugs as well.
Yes, that is a very good.
But based on the anti-BAF mechanism, do you think that the change in cell counts are compatible with the of the long effect of the BAF inhibition?
Yes, I mean, like, yeah, one limitation is really the small sample size, and then also we are not able to control for other confoundings like concomitant use of other medications. But I think for the B cell compartments is easier to interpret, and then the reduction in the peripheral B cell has been quite consistent in other study, including the post hoc analysis of this BLISS trial data. So for the B cell compartment is quite compatible. I think for the especially the PD-1 positive, CD3 positive T cell changes, we might need to interpret with caution, but it's also quite an interesting thing. So some other groups have also tried to delineate this inhibitory signal of PD-1 in SLE immunobiology, but I think this study is also still limited by a small sample size to generate whether we can ascertain these changes could be related to belimumab. I think one possible explanation would be whether there would be some PD-1 ligand on the B cell population that stimulates the T cell, and with the reduction in the overall peripheral B cell, that might lead to a reduce in this PD-1 ligand stimulation and subsequent also changes the PD-1 positive T cell population. But again, this is just a postulation or potential mechanism and cannot be really concluded with this study.
Yes, I think in clinical practice, we are not too concerned those patients who responded to belimumab. So we want to identify those who are not likely to respond to belimumab so that we can switch to another biologic, or we use combination at the very beginning. But in this study, they did not actually analyze the factors or the cell count or cell population in those patients who did not respond. And they did not report this sort of data. But this will be very useful if this data are available, because if we can do the transcriptomics of patients before treatment, we can identify those who will not respond to belimumab so that we can give the patient more aggressive treatment at the very beginning. Okay, I think because of in the interest time, that's all we got for today. So thank you for joining me, Shirley Chan, and it's great to hear your thoughts on the latest developments in lupus management.
Yes, so thank you, Professor Mo, for the invitation. It's my pleasure to join this prestigious program on the Lupus Forum.
So thank you for your listening, and you can find the slide decks for these papers at lupusforum.com. The Lupus Forum is free to access, and for all our content is free to download. So if you are not already, make sure to register for updates on the Lupus Forum. You will receive email updates when new content is made available. You can also follow us at Lupus Forum on Twitter and LinkedIn. Thanks again, and see you next time.